Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 580 of our pharmacotherapy series, which majors in geriatric drug use. The first case reads, as a new consultant pharmacist to a 60-bed, skilled nursing facility, several multiple drug use problems become apparent during initial chart reviews. A typical case is TDM, an 82-year-old man who has resided there for the past month. TDM's past medical history is significant for hypertension, depression, constipation, long-standing mild cognitive impairment that is now worsening, and dizziness. In the nurse's notes, it is documented that TDM had a fall when getting out of bed last week. At admission, TDM's weight was 165 pounds, a blood pressure of 100 systolic 60 diastolic, a pulse of 85 beats per minute, and a temperature 98.6 degrees Fahrenheit. Subsequent vital signs are not recorded systematically into his medical record. Sporadic documentation in the nurse's notes indicates little change from admission values. No laboratory information is available at this time. TDM has no known allergies. Current medications include amlodipine 10 mg daily, diltiazem CD 240 mg daily, hydrochlorothiazide 25 mg daily, quetiapine 300 mg daily, lorazepam 0.5 mg every 8 hours as needed for anxiety, docuzet sodium 100 mg twice daily, milk of magnesia 30 ml daily, temazepam 15 mg at bedtime, and acetaminophen 1 to 2 325 mg tablets every 4 to 6 hours as needed for pain. TDM follows a 2-gram sodium diet. TDM is ambulatory and takes his meals in the facility's dining room. He is not in any acute distress, but the nurse's notes indicate that TDM is often confused and complains of dizziness when ambulating. His weight has decreased 4 pounds since being admitted. My first question to you reads, what should be expected of this long-term care facility with respect to medication monitoring? Under the CMS-mandated regulations, the establishment of goals of antihypertensive therapy and monitoring for these goals are required. TDM's blood pressure should be measured and documented in his medical record with a signature and date on a regular basis. TDM's dizziness, a symptom of orthostatic hypotension, may be caused by overtreatment of his hypertension as evidenced by his low admission blood pressure. Orthostatic hypotension occurs in 10% to 30% of older adults and is most common when patients first arise, indicating that this may have been the cause of TDM's recent fall. TDM is being treated with 2 calcium channel blockers. Discontinuation of one of them should reduce his dizziness and help prevent future falls. Because TDM is being treated with a diuretic, monitoring should include a chemistry panel for electrolyte abnormalities. My next question to you reads: what changes should be made to TDM's medication regimen? In the admission workup, TDM was described as having a long-standing history of mild cognitive impairment, but subsequent nursing notes suggest that his symptoms of disorientation and confusion worsened quickly after admission. Chronic dementia is not normally characterized by rapid deterioration of mental acuity. This should raise the suspicion that a reversible factor could be responsible for TDM's mental decline. Potentially inappropriate drug use in older adults living in the community and in long-term care is well documented. The cognitive impairment of chronic degenerative dementia can be greatly exaggerated by TDM's treatment with lorazepam, temazepam, and quetiapine, especially with higher than recommended dosages. Benzodiazepines may also increase the risk of falls and bone fractures in the geriatric population. Antipsychotics are some of the most commonly prescribed drugs in nursing home residents. It is only appropriate to use these agents if the patient's behavior is considered to be a danger to themselves or others, including staff, impairing the patient's daily functioning, interfering with the staff's ability to care for them, or causing distress to the patient, i.e., frightening hallucinations. Antipsychotics may be unnecessarily prescribed for anxiety, insomnia, confusion, or failure to conform to the institution's standards for behavior. Antipsychotic use in older adults with dementia has been shown to be associated with a 1.7-fold increased risk of all-cause mortality compared with non-users. Primary reasons for death were heart failure, sudden cardiac death, or pneumonia. Federal regulations require that these drugs be used for a specified condition, at the lowest possible dosage, and for the shortest possible duration. Regulations also mandate tapering of doses and careful documentation of all clinical assessments that justify the ongoing need for antipsychotics. In light of the atypical deterioration of TDM's cognitive function, the doses of all psychotropic medications should be gradually tapered down to the lowest effective dose and/or discontinued if appropriate. It may not be appropriate to make multiple changes all at once. However, a plan should be developed to target the medications that are likely responsible for TDM's decline in mental status. A baseline assessment of TDM's cognitive function and psychiatric status should be performed by a geriatrician, psychiatrist, or clinical psychologist to establish the presence or absence of psychotic behavioral disturbances or depression. If any of these disorders are present, then each should be managed with appropriate non-pharmacologic interventions and drug therapy that includes appropriate therapeutic doses and duration of treatment. The American Geriatrics Society, abbreviated as AGS, updated the Beers criteria for potentially inappropriate medication use in older adults in 2015. This evidence-based review outlines medications that may lead to adverse events in older adults. Other helpful tools available include the screening tool of older persons' potentially inappropriate prescriptions, abbreviated as STOP, and screening tool to alert doctors to right treatment, abbreviated as START criteria. The combined use of these tools along with clinical judgment is meant to guide clinicians in drug selection, to help decrease exposure to medications that may increase the risk of adverse drug events, and to support the safe medication therapy of older adults. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 581.